Bismillahirrahmanirrahim. Assalamu alaikum. Can you all hear me? Can you all hear me at the back? Thank you. Okay. First of all, I would like the panel to please come over here and have the seats. Mr. Tanveer Hussain sir, who is the team lead of Mnemonics, please have a seat, sir. Mr. Ayaz Sumro sir, who is the health and nutrition specialist from UNICEF. Dr. Mohammad Imran Khan, Dr. Ali Turab, and Dr. M.N. Lal. Okay, Mr. Aziz Mevan sir.
जब बोल रहा हूँ मैं गाड़ी बोल लूँगा, I'm comfortable.
I welcome the esteemed panel and you all to this childhood immunization session on the breaking the barriers to childhood immunization in Sindh, local solution for local problems. There was a saying from Seth Berkley, CEO of Gavi, the Vaccine Alliance: the return on investment in global health is tremendous, and the biggest bang of the buck comes from the vaccine. Vaccines are among the most successful and cost-effective health investment in history. My name is Dr. Mohammad Fareeduddin, and I am a consultant pediatrician and working as the head of the pediatrics of medicine for more than half a decade at Indus. And before Indus, I was at an ICH where I served as in charge of PICU for more than 12 years. I am also the member of expert review committee of Sindh province for polio eradication. Today I will be hosting this program and the moderator of this panel discussion. In this session, as the session the title suggests, we have all assembled here today to discuss the current immunization situation as well as strategic challenges to expanding the coverage and innovative solution in place for improvements. As you all know that vaccines are the most inexpensive means of improving health and lowering morbidity and mortality caused by infectious diseases in the developing world. Despite significant advances in science and technology, even within Pakistan, the implementation of global vaccination coverage remains a pipe dream. Many obstacles and challenges remain, and imaginative and bold solutions are required. Recent initiatives based on international cooperation, philanthropy, and goodwill promise will promise a bigger future for those in need living in the developing world. First of all, I'll have the introduction of this panel. First of all is Dr. M.N. Lal, who is my teacher too, and is a renowned pediatrician and a seasoned public health expert. He is also the director of Child Survival Program in Sindh. In addition, he is also the coordinator for the IMCI related initiatives in Pakistan. He has contributed significantly to the revival and rollout of this essential training. Recently, he successfully upgraded the IMCI course from 11 to 6 days, which for sure will increase its implementation and demand. Welcome, sir. Dr. Ali Turab is the Deputy Director at IRD. Ali has a Master of Public Health with a focus on global health from the University of Sheffield in the UK. He has more than 8 years of experience in research, design and implementation, and advocacy for improving newborn survival and nutrition, and reducing childhood infectious diseases in Pakistan, Afghanistan, Eritrea, and Kenya. Ayaz Sumro, then we have Dr. Imran Khan, is the director at the Center of Excellence in Women and Child Health at the Aga Khan University. Dr. Khan earned a PhD in international health with a focus on vaccine preventable infectious diseases from Bloomberg School of Public Health, Johns Hopkins University. Dr. Khan has been working on projects focusing on effectiveness evaluation of public health interventions within the field of maternal and newborn health in Asia and Africa. Dr. Ayaz Sumro, kindly would you please give your introduction over here too, because this is not mentioned here.
My name is Dr. Ayaz Hassan. I'm currently working with UNICEF as a health secretary specialist and supporting government of Sindh for strengthening routine immunization in the province. Besides supporting for the maternal and newborn health in the province. And during discussions, I will discuss something what I have completed. I did my master's in public health from Law University of Sciences and MSc in Health Policy Management from Offan University.
Okay. Thank you very much. Next, Tanveer Hussain sir.
I am Dr. Tanveer Hussain. I am a public health specialist and working in the area of supply chain management since last 8 years. Currently working with in US at Global Health Supply Chain Management.
Thank you very much. Mr. Aziz Memon is a humanitarian, industrialist and diplomat who serves as the chairman of the National Polio Plus Committee Pakistan for Rotary International and has dedicated his time and resources to completely eradicating polio from Pakistan. His efforts towards community service include education, food relief, health and many other initiatives. The President of Pakistan has conferred him with the Pride of Performance Award for his dedication to public service. I thank you all for being over here. Okay, before I invite the presenter, I would really would like to start this discussion by briefly introducing the situation what we are facing right now. We all know the impact of timely immunization for preventing childhood disability, morbidity and mortality. Despite global coverage, despite global progress to improve immunization coverage in the last decade, coverage rates in Pakistan have remained low with marked geographic variation within the country. Sindh with coverage for fully immunized children at 35%, lags behind Punjab, which is like 56%, in improving routine immunization coverage and timeliness. Since pentavalent 3 coverage at nearly 53% can be considered modest at the best. Low immunization coverage leads to children's susceptibility to vaccine preventable diseases and has contributed to Sindh's high infant mortality rate, 104 per 1,000 live births, compared to the national average of 88 per 1,000 live births. Broadly, the challenges currently faced by API can be coupled into demand and supply side challenges. On the supply side, we have issues arising due to poor management, lack of monitoring and inadequate supervision of staff, overburden from frontline health workers and low quality of data and reporting. Similarly, on the demand side, parents do not bring their children for vaccination due to lack of education, information and misconceptions about vaccines, inability to remember vaccine dates and due to the opportunity cost in terms of time and wages for going to bring the child to the EPI center. In this era of rapid technological innovations, the mobile technology has spurred mobile technology based health solutions, which is mHealth, which are becoming increasingly common in the developing world as well. Within the field of immunization, one of the most prominent features of the trend towards mHealth innovations is the Digital Immunization Registry, DIR. Many developing countries like Mozambique, Haiti, Thailand, Guatemala have developed DIRs. Just last year, the Health Department, Government of Sindh, has also launched a DIR by the name of Zindagi Mahfooz in the entire province. For the first presentation, I would like to invite Dr. Ali Turab to provide an overview of Zindagi Mahfooz Digital Immunization Registry and its scale-up in the Sindh. Dr. Ali Turab.
Immunization registry, which we are going to talk about today, which is Zindagi Mahfooz. So, as Fareed Saab has said, that these digital immunization registries, they have been scaled up in various low middle income countries, expecting certain kind of objectives and then outcomes. So, the objective of our registry was to increase the routine immunization coverage and the timeliness using low-cost technology and behavioral economics and generate real-time actionable data for monitoring and evaluation. So the pilot phase of this program was funded by the United Nations Foundation through the UN Secretary General's Innovative Working Group grant. So this is a quick overview of the intervention itself. The immunization registry with quick response code-based identification. So you see number one, which is childhood data recorded at the enrollment. So when a child walks in at a immunization center, so we record the data of that child in the mobile phone interface. So if that child was already registered, we already have a QR code. If this is a new child for immunization, we give him a QR code and then fill out the information. So in the second phase, this information through the mobile phone, it goes to a database, and all the information of such children who are vaccinated, they are stored in the database. So the third picture which you see, it's the mobile phone interface itself. So the green ones show the antigens which are vaccinated. The child is updated for that particular antigen to be vaccinated, and the red ones, they are the ones which were missed. So I'm going to go through a quick cycle of this registry, how it works. So we have already talked about it briefly now, but this is what happens. So a child comes in, and if it's a new child, you give a QR code, and if the child was already immunized, so the child already has a QR code, you scan that QR code, and all the information about the immunizations for particular antigens which the child received and for which the child is due, they show up. So this is in this picture. If you see this window, that would tell you that the child was vaccinated for BCG and OPV1, and Penta1 and OPV and PCV are still to be scheduled. So in addition to the mobile phone registry, it also has interactive SMS reminders. So this is the second intervention. So the child, the family of that child would get a reminder SMS 1 day prior to the immunization date of that child, and then a second SMS reminder on the day itself when the child needs to get the immunization, which is the scheduled date of immunization. And the third reminder is after 1 week. If the child misses that vaccination, then a reminder is sent after 1 week. So these reminders were two-way, these SMS were two-way SMSs, they were interactive. So the family of the child who were registered for immunization, they also had the ability to send us back the SMSs so that, you know, these SMSs, they were qualitative data, and they helped us a lot in developing and improving the features of our immunization registry. So I'm going to talk about the pilot which was conducted at 12 centers of Kurangi between 2012 and 2014. And so this was a cohort of about 25,000 plus children who were enrolled in this digital immunization registry. So as you can see, so we have shown you a comparison in bar graphs between the PDHS 2012-2013 coverages and the digital immunization registry coverages of particular children. So this information shows you how the immunization coverage increased after those children, they were registered in the digital immunization registry. So for Penta 1, the PDHS tells us that there was a coverage of 65%. But with the digital immunization registry, in those 12 centers of Kurangi, this coverage increased from 65 to 84%. So subsequently, if you look at Penta 2, so the coverage, the PDHS coverage for the province is about 57%, but with the digital immunization registry, the Penta 2 coverage increased to 84%. So on and so forth for Penta 3 and Measles 1. So I'm going to talk about fully immunized child, which is taken as a child who has received BCG shot as well as 3 Penta shots and 1 measles shot. So this is a fully immunized child here. So for FICs, the PDHS tells us that the SIN has about 29% of fully immunized children. Whereas with the registry, through the registry, this coverage increased to 54%. So this is a slide detailing some outcomes from that pilot. So I've already told you that it started in 2012, June 2012 to be precise, and the application was launched in 12 centers of Korangi. So we trained around 15 vaccinators who were fixed at the site vaccinators, not the outreach vaccinators, and almost 25,000 plus children were enrolled in this registry and received immunizations, and the proportion of fully immunized children increased from 29 to 54%. So now we'll go through again the interface of this digital immunization registry for mobile phones as well as the database. So these screenshots are for the mobile phone interface. So number one, it tells you that this registry has the capacity to capture all the biodata of those children which were previously used to be recorded in paper-based forms. So this is the shift. And then the second thing is that once you have the data in and the QR code in place, so this the registry has the capacity to predict and tell you that what vaccinations were done to the child and what vaccinations are remaining and how to schedule the next vaccinations. So this is the dashboard linked to this digital immunization registry, and this dashboard is intended to be used by the middle level managers for the monitoring and evaluation purpose, and also so that they have access to real-time data, so that using that data actionable decision making can take place. So this screenshot shows you the daily child register record. So this is for a particular immunization center, maybe a BHU or maybe another immunization center at a hospital, maybe a secondary or tertiary level hospital. So whatever vaccinations took place on that particular day, they will show up with all the information of that particular child for previous and upcoming antigen vaccinations. So, and then the current system is that there is a daily register and then there is a permanent register. So this is a screenshot of the digitized permanent register. So after the digitization, the register looks like this, that for a particular child you have all the biodata information as well as the information of particular vaccination that child has received. So this shows the campaign child records for SIAs and other campaigns which happen from time to time during a month's time, which is the outreach essentially. So you also have information from the outreach for that particular child or any particular child. These are the women records for vaccinations. So this dashboard would also have a digitized EPI card, so a middle-level manager can have a quick look that what vaccination have been administered and what are remaining for a particular children. And so this is the attendance record of vaccinators. So this would allow the middle managers to know what time schedules their teams were following, and for accountability, this is really, really important. So it works in two ways. One is that once the vaccinator starts using the mobile phone on that particular day in the morning, so that the vaccinator's attendance is already marked. And the second thing is, since this whole system, the Zindagi Mahfooz, it also has GPS and GIS tracking features. So if you geofence particular workers, so those workers, whenever they are in I don't know, maybe 100 meters radius of that center, if they show up in that radius of that center, so their attendance is already marked, and there is a leverage of time for plus minus 10 minutes for their attendances. This is a picture of a particular vaccinator at a particular coordinate. So this dashboard will also allow the managers to track the progress of their vaccinators. So for a particular vaccinator, if you put in the name, the ID of that particular vaccinator and the vaccination center. So you can browse through all the vaccination records that particular vaccinator has administered for that day, maybe month. So you can set those limits. So this is the progress of BHUs, similar to the previous slide. So in the previous slide it was for the vaccinator. This is for the health centers which are offering vaccinations. So health center wise, you can look at and you can go through all the vaccinations that were administered within a particular time frame. So this digital immunization registry is mobile phone based, and it also has a web interface. So the mobile phones, they are linked to the web, and then there is a centralized database for data collection across the dashboard and the mobile phone interface. So it also has the RFID QR code, which makes it real quick. You just take the photo of that code and all the record of that child pulls out. So it also has built-in interactive SMS reminders. It also has offline mode. For example, in a geographical area, the mobile phone coverage and the internet coverage is not there. So you can always collect data, and once you collect data and you go to a good service area, that data is synced to the main database. So this it also allows for the maternal vaccinations to be captured. So it's essentially a household registry, and it has a built-in DSS for routine and catch-up immunizations. It also allows us to mark and track attendance and GIS, which is the location tracking of vaccinators, whether they were on a particular day according to the microplan, were they present in that area vaccinating children, be it the facility-based vaccinators or the outreach-based vaccinators, both. So it also allows you to generate a virtual immunization certificate once a child is fully immunized. So you can, as a memento, you can generate the certificate and give it to the family of that immunized child. And then it also allows us to gather defaulter lists, that what children and what is their proportion in a particular area who defaulted particular antigens. And it can also allow for the middle managers to plan their micro plans for vaccinations for fortnight, 1 week, a month, depending on their own. So a couple of features are currently under development, and one is the predictive analytics. After this has been piloted already, and after the registry has this feature, this would give us the it would allow us to predict that what children will be most likely to default based on certain social demographic and economic indicators. So there's the algorithm behind this predictive analytics. It's a machine learning thing, and once you have those indicators fed in, so it can predict what families and their children are most likely to default. So, and in these upcoming features, we will also be able to record the vaccine adverse events and surveillance, and also the illness and treatment history data. So until now, there have been 155,000 plus children who have been vaccinated since June 2012. June 2012 was the rollout of pilot program. So since then, there has been an improved visibility of routine EPI services. It has enabled improved Penta-3 and FIC coverages to be achieved. There is better vaccinator performances, and there have been increased motivation and work hours. So overall, improved interaction with clients. So I'm going to talk about the scale up now. So the government of Sindh has adopted this digital immunization registry, and IRD is the technical partner for implementing this digital immunization registry throughout Sindh. So there are 2,500 vaccinators, around 500 LHWs, and 1,600 plus centers in 29 cities, where this digital immunization registry will be implemented. And we hope to immunize 2.8 million children under the age of 2 years to be vaccinated. So this is the phase-wise implementation plan of this registry. So we have started from Sindh, from Karachi division, and then we spread out in Sindh. So the last district which received training, which is receiving training right now, is Larkana. The last division is Larkana. So this is the progress till date. And if you have a look, that in Larkana and Mirpur Khas, the trainings, they have started. So once the trainings of the vaccinators are over throughout Sindh, so the next step is the training of middle managers on the use of dashboard, and then the subsequent ability to have actionable data for decision making. So the trainings of mid-level managers is scheduled to be started from February 5th of February 2018, and we hope to complete these trainings by 19th of March 2018. So this is the status of centers who have deployed this digital immunization registry and have become live. So if you look at Karachi, so there were 297 total centers, and this registry is live now in 277, and in Hyderabad, out of 197, 175 is live. So if you look at Larkana and Mirpur Khas, since the trainings have just been rolled out in those divisions, so it's not much live centers there. In Larkana, 62 are live, and in the next in this month, we hope to have greater numbers of live centers in these two divisions. So in addition to Pakistan, this registry is also being rolled out in Central African Republic, and other than that, the future areas of rollout will be in South Africa. We are having negotiations with the authorities there to roll out this registry, and this registry can also be a part of Open SRB, which is also a registry for capturing information on the delivery and also the healthcare providers on a digital format, and to be linked and integrated within the public health system. Thank you very much.
So are there any questions that you would like to put on, please?
Thank you, Dr. Turab, for an excellent presentation. This program is the need of the hour because it will increase the accountability. But I have certain concerns about it. As far as being just it's a scientific discussion. You have compared your program with the PDHS 2012 and 13. The new data is available, and it's a mix setup compared with the PDHS, which is very old now. It was 2012, the survey was conducted till 2011. Yeah. And the mixed survey and your this pilot study is of the same period. So practically, I have this with me. There is no significant difference of the compliance between the mixed survey results and your results. So interpretation of many factors which have used are not apparently justified. I have no doubts about your program and these things. These are the need of hour because of bogus reporting and the wastage of vaccine, pilferage. There are so many things. But be scientific, this is not justified. You have shown 3-4 things of better compliance and these things. There should be some improvement, but this is not proven.
So when you talk about mix, I think it's mix 2014, right?
Yes, yes.
So the thing is that I told you that we rolled out our pilot in June 2012. So if you say that we have compared it to our older data, that may not be true, because mix was after we rolled out our registry. So mix is more latest data compared to our registry data for pilot.
Same duration. You have studied from 2012 to 14, and mix was published in the end of the 2014. Data must be some months before that. Number one. And number two, there are more things about your program. That is an excellent thing. I have no objection to the program. But it will improve the compliance of those who are registered now. In the Sindh, already there are 70 mixed data showing that only 76% received the first dose of the BCG. Besides your program, we need something more capturing those 24% who do not even start their vaccination, who do not get the BCG. Once the person is in your network, you will send the messages, he will be coming. That is an add-on thing. But those who are not coming to vaccination center, who are not coming, they should be considered. Let me complete the things. Number 3, that tetanus immunization TT doses are an ignored phase. We know that still the gynecologists are giving 2 TT doses in the last trimester. They are not using the 5 TT schedule now. So I'm not clear how your program will take care of this. This much
we have already mentioned in the presentation that this registry is capturing maternal immunizations and tetanus, which is tetanus toxoid. So it's a part of the registry.
You are sending the messages to the mothers also for the tetanus immunization. These things, is it included in that?
Yes.
Yeah.
For all the vaccinations.
You have not shown any data.
Yeah, so
we were
sorry about that. We were child-centric.
We like to know it will be very.
We were much more child-centric here.
Interesting data because our EPA schedule for the mother TT is not being followed almost not at all. No?
So it is for mothers as well. It is for
tell
mothers.
How is the compliance in that? Those are the mother completing TT5 or not?
So unfortunately, I don't have that data with me right now, but it is for the mothers, and they are also receiving SMSs. And coming back to your first question, so the thing is that you mentioned the mix had an estimate of 74%. So our registry mix for Penta-1 was 74%. So our registry has about 84. So which is
Slightly better.
Yeah.
No,
so 10%
your comparison I think is not valid. You are comparing the child who registered with you. Second dose getting 84% of those children are getting 84% of those children coming for the vaccination. But mixed data is showing that overall children the dose is given to 69%. It is overall the population, and now you are taking the population out of those who have registered. There is a difference between this. Am I clear with that? भाई देखिए आपके प्रोग्राम में जो लोग आ रहे हैं उनमें से 84% बच्चे सेकंड डोज लगाने के लिए आ रहे हैं.
No, when I say that 84% received Penta-1 in our registry, so that is the comparison with the population of under 2 children in that area.
How does 84% number
that's what I'm
came
saying.
from where?
So for Kurangi, that's what I'm saying. So for Kurangi, you have an estimated population of children who are under the age of 2 years. So from that estimated population, we are giving you the number who received the Penta-1 vaccination, which is 84%. It is not just, we are not comparing, we did not give you this value by comparison within the registered people, no. It is from the whole population.
It's from the whole population. The data is from your record only.
And since nobody knows the whole population, the census was done recently. These are all estimates that within a particular area, you get estimates like the EPI get estimates for the projected population of that area, and then they make and set their targets. So this population is from those estimates. That, for example, there were 200,000 children there, and so from those 200,000 children, this much received Penta-1, and that is the proportion for you.
Okay, you can use that data set, but there is a difference in the methodology.
And then there is another thing. So this was a pilot, and this was not a full-blown implementation, right? So when you talk about full-blown implementation, then there are a lot other factors interplaying as well, and then the force of that thing is completely different from a excluded pilot. So I agree what you are saying here. So I hope I've made the clarification good enough for you that the proportion of children which we told you were vaccinated were from that population in that Kurangi centers, from the expected population of 102 children in those centers.
Thank you.
Whom are you representing?
What?
Whom are you representing?
I am representing IRD, Interactive Research and Development, the technical partners of Government of Sindh, Department of Health for scaling up this digital immunization industry.
By whom are you representing?
I am a pediatrician. I am General Secretary of Pakistan Pediatric Association. We have to see, the program is very good, whether the glory picture is realistic or not. I am not criticizing on the program. This program is being implemented in a number of countries. There should be accountability, but being in a scientific session, we are not talking in the public. In a scientific place, we have to see the glory picture which are looking whether it is right or not. That is my point.
I have in public sector hospital, I was impressed from the program, as you said very rightly, and we started with this program in civil hospital.
Yes, sir.
So if you just look to the BCG, the BCG in civil hospital we give from morning till the late night, 8 p.m. because deliveries are occurring throughout the day, So all the babies who are born and that day they vaccinated. And Dr. Khalid, you very rightly proposed the program is very good. The coverage went to the 85%, So the BCG registry increased to the 85%. And then those children who will be given the BCG, they came for the DPT, and through the messages and reminders, those children who got the BCG registered, they will be, through this registry, they will be given the messages for the next DPT 1 or DPT 2 or 3. So there is a significant, change occurred by this, And
significant change जिंदगी महफूज प्रोग्राम से नहीं हुई है, या बीसीजी बच्चों को लगा रही है कि डायरेक्टर अभी मौजूद नहीं है. अभी ये डिस्कशन इन डॉक्टर इमरान के से अलग हटकर है अली तुराब के, क्योंकि हमारे यहाँ हम जो वैक्सीनेशन का सिस्टम कर रहे हैं, अब हम जो करते हैं कि बच्चे जमा करके बीसीजी लगाते हैं, बीसीजी की सप्लाई कम है, इट्स नॉट अवेलेबल फ्रीली, पैसों का भी नहीं मिलता. तो जब बच्चे ज्यादा जमा होते हैं, जब बीसीजी लगाते हैं, तमाम हॉस्पिटल से बच्चे डिस्चार्ज होकर घर चले जाते हैं. हफ्ते में 2 दिन 3 दिन बड़े बड़े हॉस्पिटल में बीसीजी लग रहा है, और बीसीजी पीपीए वाले बीसीजी बच्चे गिन के देते हैं. मैं एक हॉस्पिटल को, प्राइवेट हॉस्पिटल को सेटअप में पीपीए सेंटर चलाता हूँ. 300 बच्चे पैदा होते हैं, वो 300 डोजेज देते हैं. आज 10 बच्चे पैदा हुए, कल 7 हुए, फिर 12 हुए, फिर 8 हुए. अगर आप एक वाइल खोलेंगे, 20 बच्चों को वैक्सीन लगता है, 20 बच्चे आपके कतार में नहीं पैदा होंगे, 13 होंगे या 14 होंगे. तो अगर आप हफ्ते में 2 दिन या 3 दिन में लगाएंगे, उसमें 6-7 डोजेज मिस होती हैं. वो गिन के देते हैं कि 300 बच्चे पैदा हुए, 300. तो इसी तरह से और वैक्सीन का हाल है. हम वैक्सीन को बचा रहे हैं, बच्चों को नहीं बचा. ये एक पॉइंट है. अभी और डिस्कशन आगे होगी तो हम आगे इसमें चलेंगे. और भी बहुत सारे कंसर्न हैं. लेट्स मूव फॉरवर्ड.
सही. Okay, thank you very much, Dr. Fareeduddin. Dr. Fareeduddin has a very broad view of this vaccination. He has been serving for a long time. Okay, we'll continue this discussion. My question would be from Dr. Ayaz, that what are the main challenges of achieving this global vaccine action plans target of 90% coverage? What do you think so? What are the problems that are basically there?
Dr. As you have mentioned yourself, that in our country, poor management is on top. It means accountability systems are weak in our health system. And we don't hold people accountable for their actions, for their responsibility, for their jobs. Definitely they are not performing their duties. The major thing is this, to help people who are responsible at various positions held accountable for them. In Punjab, the Chief Minister is having a stock account every month, calling all the status officers and asking them what is the status of immunization in respect to districts. And if the children are not vaccinated a certain percentage, why they are not vaccinated, then everybody is feeling that they are held accountable for that and they are taking actions which are required at their respective districts. In Sindh, unfortunately, there is no system available. There is no system of stock taking, there is no system of management level meetings. DHOs are accountable for polio only, and they are very much concerned about polio activities and polio coverage. The routine immunization have been lagged behind because of strengthening polio systems and polio vaccinations. There are several campaigns each year, almost every month we have a polio campaign, and whole human resource which is available at the district level, including vaccinators, lady health workers, health facility staff, medical officers, everybody is involved in polio campaign and polio activities.
You are from UNICEF?
I am from UNICEF. So currently what we are doing, we are working on polio eradication program and EPI. We are focusing on them. We are strengthening and we are bringing them together. This is the part of me. And we are focusing on that. They should work collaboratively and work closely. In August, we had a measles campaign in Karachi, which has brought a collaboration of UNICEF, EOC, polio and EPI. which brought coverage of more than 94% in Karachi only. There was a huge activity and whole polio workforce was involved in this routine immunization activities of cases, which brought very good results. Why? There was accountability. All the town health officers, the district health officers were brought in a platform. They were told that this is the campaign and you have all to be involved, all resources to be utilized to improve the coverage and cover the children whoever are available. And this brought very good results. So on the top, this is management issues. Secondly, we have a monitoring. Our monitoring systems are very weak. In Sindh, almost there is no monitoring system existing. So currently UNICEF has developed a plan where Polio 1, Polio Tier 1 and Polio Tier 2 districts. We will provide support to the API program and EUC. We will fill the gaps at community level. Where there are no lady health workers, we will provide them community health workers. And where there are no vaccinators, we will provide them vaccinators. And EPI is also recruiting 552 vaccinators for Karachi only. Advertisement has already been done and they will be hired in the course of 2-3 months' time. They will be on board as well. So each there will be teams which comprising a vaccinator, a lady health worker and a monitor. They will be moving in the each union council and they have to cover minimum 16 EPI sites in each union council. They will be moving around the whole union council. Each month they have to work 4 days every week and they have to roam around, move around different sites. And the CSW and LHW will register children which are living in their community. So once it will be registered, they will come up for the vaccination. And this system of data management, IRD has already launched this system and that will be utilized for this purpose. And the coverage, registration of children, then coverage, whichever are missing, then they have to read them. And mechanisms will be, course of time will be developed how to read them. If they are not coming, people, they have some latency, some issues, then we have to see and how we have to reach them. And this every week there will be a meeting at the district DPCR, we call it Polio Control Room. And all the monitors will come over there, they will share the issues and constraints and problems, whatever their problems is there. And this way Deputy Commissioner will chair that meeting and they will head accountable people who are responsible to make them responsible and do these activities. So this is one of the activities which is already started. And one NGO CSO is hired, which is recruiting the people, filling the gap. Then it will start monitoring from coming on 1st February. And it will, I think, bring some good results. We hope better for this. So I think this is the way we can go.
So this is a very big mass sort of program. So are there any human resource issues that you are also facing at this
Yes,
time?
we are also planning to fill the gap. Wherever there is a no vaccinator, we will be provided. Where there is a near no LHW, we will provide a CSW in order to fill the gap. And monitors will be from the third party as well, besides the monitoring system of government, the existing government system. So it will complement each other. Even polio teams will support them. The CVBs, community-based volunteers, polio reading officers, they will also support these teams to improve the routine immunization. So I think this is the whole.
Are you still facing these religious taboos thing and the other cultural issues that we often face with you?
I think there is no much resistance.
No much resistance.
As it has been previously noted. Currently people are receiving and they are ready to do that, to get the children vaccinated, but the fact is that people want vaccine to be reached at their home, which is not possible. Polio drops, can you send people to give the drops to the child at their doorstep? For vaccination, as Hassan is saying, for BCG, this is a problem. Wastage is a problem and over the years it has been discussed. This is not being sorted out. Currently, PDAP has written letter to all the district health officers that if you have children and you need open the while you thought that these children will not come back, then you can utilize that vaccine and give it to them. Don't think of vaccine saving, but provide vaccine there. This later the late issues on PDAP.
Sir, on point of clarification, hasn't the government of Sindh appointed a separate EPI officer responsible for the operation in the district, and not district health officer is not handling that? Is that so?
No, not yet.
But is that a scheme?
Under PC1, there is a plan to hire district immunization officers and Talika level immunization officers, but that has not yet materialized. There is under process of approval with the government, but they are not yet, PDP did not get that approval, so that process is not yet started. But it is part of PC1.
But it is part of PC1, it will be done.
It will be done.
Yes.
But you said that routine is suffering because of polio. Who told you that?
So this is the findings of several studies. Like when vaccinators are involved in polio campaign and polio activities, they were utilizing 2 weeks of their time for polio campaign activities. So this is why now the policy is there.
Both are separate. And
Yes.
it is not correct to say that routine has suffered. Routine has suffered because of the total collapse of the health system of Pakistan, whether it is Sindh or Punjab. It is a sad thing. And
Right, sir.
where we are, what we are talking of, third world countries have done this long time back. We introduced digital mapping in Bangladesh in the year 1999, and Bangladesh became polio free in 2003. Today their routine is 72.5%. It's sad, you know, and we were tracking with the digital when we introduced in Pakistan also 7 years back. Digital technology, and we were tracking from the pregnant mothers, not from the child born.
No, the issue is this, the vaccinators, currently, you know, there is a letter written to all district officers, the vaccinators should not be involved in polio campaigns.
Yes, yes.
These are gradually vaccines have been taken out of the polio campaigns.
Yes.
So this has been proven, this has been understood, that
ये
their
बताएं
involvement is
ये तो सब छोड़े, ये बताएं ना कि इंडस जो है ये मुझे नहीं है और 4 लोग ये पीछे ये माइक ले क्या करूँगा मैं ये तो इन्होंने कुछ नहीं किया। इंडस क्या कर रहा है अब ये बता दो, इसलिए मैं आया हूँ सुनने के लिए।
Dr. Ali Turab, would you like to answer this?
नहीं, डॉक्टर अली तुराब इंडस को नहीं सब
क्योंकि GST और एक IRD की तरफ से है।
Indus, IRD is from Indus.
IRD is Indus.
Yes, so no, IRD is not in
IRD
this.
is not in this.
organization.
Yeah,
अभी
IRD is
जो 3 महीने पहले जो ये डॉक्टर फजल ने साइन किया था इंडस के साथ टू इम्प्रूव द रूटीन, तो वो क्या हो रहा है उसमें बताएं ना वो क्या कर रहे हैं।
So IRD is the technical partner here. So the government of Sindh has a partnership collaboration with Indus Hospital as well as IRD. So Indus Hospital is a part of this scale up as technical partners.
क्या what is happening in that?
So we have told you.
ये आपका ये
This was Indus and IRD.
but you are saying it is from 2012.
That was the pilot. That was a pilot study. उसके बाद मैंने आपको रोल आउट एक बताया कि इस वक्त हमारी जो 6 डिविजन्स हैं वहाँ पे ट्रेनिंग्स कंप्लीट हो गई हैं, एक डिवीजन में रहती हैं जहाँ पे हो रही हैं ट्रेनिंग्स वैक्सीनेटर्स की, और तकरीबन सेंटर्स का स्टेटस भी बताया था कि कितने लाइव हो गए हैं आपके कराची डिवीजन में, तो इट्स मोर देन 90%, बल्कि बाकी जो 4 डिवीजन हैं उनमें भी मोर देन 90%, अभी लाड़काना में इतने 10-15% सेंटर्स लाइव हुए हैं। सो विद इन दिस मंथ हमारी ट्रेनिंग्स वैक्सीनेटर की ख़त्म हो जाएंगी फॉर सिंध, होल ऑफ सिंध, और नेक्स्ट मंथ में ये होगा कि हमारा जो मिडिल मैनेजर्स हैं, जो हमारे तहसील और डिस्ट्रिक्ट लेवल के ऑफिसर्स हैं, वो आर गोइंग टू यूज द डैशबोर्ड टू हैव रियल टाइम एक्शनेबल डेटा, उनकी ट्रेनिंग्स जो हैं मिड ऑफ मार्च में ख़त्म हो जाएंगी। सो बाय मिड ऑफ मार्च एक दफ़ा सारी ट्रेनिंग्स ख़त्म हो जाएंगी एंड इट विल बी लाइव थ्रू आउट सिंध, एंड देन देयर विल बी अ फेज ऑफ मॉनिटरिंग एंड एवेल्युएशन कि कहाँ पे ऐसे आपके वैक्सीनेटर्स हैं जिनको ऑन जॉब कोचिंग चाहिए या एकेडमिक कुछ मदद चाहिए एकेडमिक डिटेलिंग की फॉर द नेक्स्ट 3-4 मंथ्स, कि अगर कोई मोबाइल फ़ोन यूज़ नहीं कर सकता या किसी को इस तरह के प्रॉब्लम्स हो रहे हैं विद टेक्नोलॉजी एंड अदरवाइज के सर्वर पे डेटा नहीं आ रहा, डेटा बैकलॉग या इस तरह की कोई भी चीज़ें, सो वी विल ट्रबल शूट दोज थिंग्स until June this year. So hopefully within the next 6 months this will be fully up and running.
So when you will expect the results of this project to be projected to the public or to be
Yes, so when we are full, when the full scale up has happened, yes, then we will be able to share the results.
And the goal is how many? 12 years.
12 years.
Sorry, when will you be able to get to about 80% or 75% routine?
The routine immunization coverage up to 90%. So that is to be discussed, I think, at a separate goal.
Dr. Vijay would like to.
So,
MOU with government is to provide technical assistance to the government also in building their capacity and rolling out this project. So that is till 2018. If government intends or there is any need, okay, we should be in the field for more capacity building and rollout. We will be there for service. So it is ultimately the government's
Presently
job.
it is up to 18.
Yeah. So
So
the government intends
coverage
after that we will be providing our
So
services.
once it's implemented throughout Sindh, so maybe in the next 1 year you will have immunization more than 80% throughout the province.
Are you sure?
Hopefully yes.
आपको जो
So
प्रोग्राम
if it is properly implemented, why not?
आपको जो प्रोग्राम है ना ये कंप्लायंस थोड़ी सी बढ़ाएगा. जो लोग एक दफा वैक्सीन लगाएंगे उनको मैसेजेस जाएंगे. सेकेंडली अकाउंटेबिलिटी बढ़ाएगा. ओवरऑल कवरेज करने के लिए इसके साथ एडिशन में कुछ और चीजें भी चाहिए. वो भी हम उसमें डिस्कस करेंगे. दिस इज नॉट एनफ बट इज दिस वन ऑफ द एसेंशियल एलिमेंट की आपका जो प्रोग्राम है ये एसेंशियल है.
This is the building block, that's the cornerstone.
Sir, this is just a tool. It enables us to monitor remotely people, those who can't be monitored on a regular basis. We don't have resources to monitor 3,000 vaccinators in the field. It allows us to remotely monitor all the vaccinators at different layers. For instance, if DHO is assigned to monitor 15 or 16 vaccinators, I think 15 or 16 I think are not a difficult job for a DHO level person to monitor them sitting at a dashboard in his office and looking at their activities in the field. Okay, who has shown up, who hasn't shown up today. Absenteeism is the first problem in our field. Like you said, it has badly collapsed because of the whole system has collapsed. So what we have been doing, we have been always going in the field and coming back with the data, always showing the problems in the field. What we have done here, we have showed a solution which could be the possible solution for the issues we are having at the moment. So it allows us to monitor children as well as vaccinators and as well as middle level managers. So the QR code identification number allows us to monitor children in the field and track children if a child has got vaccinated or registered from one center and then has moved to other centers, then if our program is all around, then if he shows up at other center, it can be tracked through a unique QR code identifier. So what we get at the end, we get digitalized permanent register updated at the end at our dashboard. So it helps us to track, like you said, a woman. Yes, we enroll women in our program when they show up. Mostly our women show up for the TT when they are pregnant. There are barely women coming in childbearing age, which ideally they should be, but they are showing up when they are pregnant. Then doctor asks them to go and get vaccinated for TT and XYZ at 6 or 7 months. So what we do, we register mothers and we note their expected date of delivery from the month of pregnancy, and then send them SMSs, customized SMSs. Okay, congratulations if you have got any child or so, and then please take your child to the nearby EPS center to vaccinate it and provide from XYZ diseases. So it is happening. We are registering mothers and childbearing age, and we are following
the cell phone to the mothers?
No.
No.
We are collecting just phone number, and SMS reminder is sent out to all those who are included in the program or registered in our program automatically through server. So it is just a tool. There is always a man behind the machine. We need government's ownership and the will to use this tool effectively. If they use this tool, we expect good outcomes. We have piloted this in Shikarpur as well. Whole district we have for 1 year, in which we conducted baseline survey. Where in baseline survey we find out FIC was 12%. When we completed a pilot and then we conducted another survey, inline survey, in which we found out FIC was 54, which increased 4 times the district was given when it was at the lowest of it is. I should say it was a problem district because of its different geography, terrain, and the systems over there. So. So IID and Indus are both the strategic partners in rolling out programs in Sindh, Balochistan, or whatever, wherever we are going. So these programs are already at the hospitals where we have all the Indus hospital campuses in Pakistan.
And this is pilot.
No, sir. This has been piloted and proved. After that, this is a scale-up. So we are trained almost 1,800 vaccinators in Sindh, and we are live at around 850 centers in Sindh out of 1,275.
Thank you.
Thank you, Dr.
Okay, I would like to ask another question from Dr. Imran Khan. As you are from a private institute, the Ashfaque University, what role can private institutes and research organizations play to achieve the target of universal immunization coverage in Sindh?
Thank you very much for the opportunity to be here today. I think it's a really important area of discussion, and as we see that we are thinking a little more deeply, there are many issues that need to be addressed. When we talk about private sector, the private sector is very diverse, and there are different groups in it. These could be academia, the medical colleges. These are groups that are doing research, and there are groups that are providing service delivery. I think we need to look at that which role each group can play a part in. I'll start with the universities. I think the importance of immunization needs to be highlighted. 20 years ago when I went to medical school, I don't think immunization was discussed much, and I as a medical provider never thought that immunization is an important and cost-effective health intervention. And we as a group should urge the medical institutions in Pakistan, and specifically in Sindh where we are sitting today, that when they are educating people about curative services, it's also very important to give them an exposure of preventive care. And immunization should be a key when it comes to the child health. When it comes to research, of course, Ashfaque University has been engaged in a lot of research and has been behind at least HIV and pneumonia vaccine that has been introduced in Sindh, but it has been a collaboration. So all the research organizations that are working in the province, they need to work in collaboration with other groups. That could be health system delivery, that could be academia. So collaboration should be the mainstay of all the work that research organizations are doing. When it comes to service delivery, and it is really important that when we are talking about immunization, we are still forgetting that 50 to 75% of healthcare is provided by private sector. By pediatricians, by hospitals, by clinics, by not even people who are not even qualified to be doctors. The focus in the past has always been in public sector. We are always talking about EPI, we are always talking about routine immunization. But we forget that how we can bring those groups in improving vaccination coverage. For example, if we are sitting in the city of Karachi, if I ask you what is the closest immunization center close to your home, I don't know. So we need to bring those groups, and we have representation from TPA, and it's really important that we have to give this message, the lost opportunity. If a child is visiting a healthcare provider for common cold, a simple question can help promoting increased vaccination. So this is something that I think we need to do, but I think it all has to be in a collaborative fashion. We all need to understand the importance. If we all have a single vision, then we will be able to achieve it. If we all work in silos and work for our personal interests and try to be, if I'm a researcher and I want to get a publication out without thinking that what is going to be the impact of this publication on child health, then I don't think we are going to get anywhere.
Similarly, I feel that civil society organizations can also play a very active role in all these things. So what do you see?
Yeah, I think they are a very important component. Another major area that private institutions or research institutions can play is advocacy.
the issues that we are highlighting, if we have numbers behind them, we can definitely project the problem in a much better fashion. So civil society organizations can be very useful in terms of when it comes to the communities, when it comes to the people, because without them, we can never have an improved vaccination coverage if people are not on our side. So civil society organizations can play a major role there.
Okay, my next question will be from Dr. Lal. What are the challenges one can face in trainings of focal persons and the strategy to mitigate?
Okay, I think the trainings is a very important part of any strategy. You know, that's to make it successful. And the thing is that the one is the training, and then the follow-up is very important. You know, the training is important because if I talk about the IMCI, that's Integrated Management of Newborn and Childhood Illness. Now, this is a training. We have trained, thousands of doctors and other healthcare providers in Sindh, and Sindh have got, the highest number. And now, if you look to the other side way, the Sindh have got a poor IMCI coverage. So it means, these are the challenges. So once, you train the people, the follow-up and implementation is very important. And, IMCI is the one study which is a unique recommendation for the immunization, that is to first, check whether the child is immunized or not during every healthcare visit of that child. And if the child is not immunized, even the sick child, I think we have to change the, trend of the sick child to be not vaccinated. No. We have to vaccinate the sick child as well. This is very important because I am looking to the to study this how the developed countries have improved their immunization. They focus on these very important, the healthcare providers, that they should advocate immunization during their visit. So the training is important, but then the follow-up and accountability is a very important challenge for the healthcare provider and for the government as well. Government is investing a lot of money in the training, and providing the vaccination. But we as a healthcare provider should implement it. We should ask every healthcare visit that whether a child is vaccinated or not. This way we can improve this. And then training of this new ZNP program is very important because that is to give the reminder that this way the developed countries have improved the situation and has reached the goal that's more than 90%.
Thank you. How much are the refresher courses important in this aspect and for the retention of knowledge and capacity building?
Well, refresher courses are very important, because most of the general practitioners or the healthcare providers, they are busy in their clinical practice and they don't know about some of, if we just get a survey of the 100 healthcare providers, they might not be knowing what is the rotavirus vaccine which is coming in. So that's why the refreshers are very important and that should be done.
Thank you. Dr. Tanveer, relevant to your experience in VLMIS, what are the main gaps of cold chain and recommendations and improvements that you would suggest?
Well, thank you, Dr. Fareed. Main gaps in cold chain, cold chain capacity is not sufficient in the province, as we know. Condition at the province and divisional level is comparatively better, but if you go below at the district, tehsil and service delivery level, things are. In the VLMIS, there is a one component which deals with the cold chain data. Cold chain data was entered in the VLMIS, but now it needs to be updated regularly, which is not being done by the providers despite trainings and things. Because any information system, not just LMIS, any information, proper use of that system is to see what it tells, what information it gives, and then what actions on the basis of that information we need to take. And unfortunately, these in cold chain area, that is not being utilized in that way, which is ideally we want to be. I mean, things are getting better at some areas. They are bringing solar panel, ILR, solar ILRs, etc., etc. But all the actions are just in favorites. I'm doing this on my own, and UNICEF doing on their own, and not coordinated efforts. Thing is that we should use the information, cold chain capacity, and take measures to improve it accordingly.
Thank you. Dr. Turab, you just mentioned about the DIRs, and do you believe that these digital registries are finally the answer to achieving the desired coverage?
Yes, of course, because we have, as you yourself mentioned, the example of other low middle income countries like Haiti and others. So they have achieved more than 90% coverage by using these digital registries. So our country, we have a population explosion, and then we have these areas, hard to reach areas, and then the country has faced insurgency and all those things, and then you have frequent floods. So it's you need to have a system which is robust enough to capture this information, because the current systems which are paper-based, so those things, they keep sitting on the desk of their vaccinators and then their managers, and you never have the data out of those systems to have policy and planning in place. So yes, this is the way forward, and it has been shown in other countries.
So like European, this system has been evolving for last 5 years or so. That has currently started. So what do you think that what are the biggest challenges and difficulties that are being faced, especially in Sindh?
So in my experience and what I know, one challenge is the fear of the change itself, because this system is a paradigm shift from what's happening right now. So because once you train a vaccinator or a related person, so the first thing they know is that this system, other than capturing all the immunization related information, it's also going to bring in accountability. So that is your challenge right there, because we have had some trouble with people complying to the use of this immunization registry, and then at the same time you may face challenges of ownership at the level of middle managers. So this is these challenges are cross board. So other than this, another challenge which I think which has been evident from Dr. Khan's comments, it's the engagement of private sector, because private sector has been largely unregulated throughout years. So implementation of this application and bringing them in the fold of the whole of Sindh and implementing this system can be a challenge.
What is being said was that खुदा ने आज तक उसको अपनी हालत नहीं बदली, ना ख्याल जिसको खुद अपनी हालत पे बदलने का. So what do you think that collectively is there something that can be done, like ownership within the government to have this thing?
So we have ownership and ownership from the highest levels, which is the government of Sindh itself. So it now comes down to the ownership of middle managers and the vaccinators. So it's to that level now. And other than this, that for the system to function and to flourish, there has to be accountability, serious accountability measures in place. And then as we roll it out, as we go throughout Sindh, so there needs to be, and there is actually, a robust monitoring and evaluation system in place, so that through those systems we could identify people and their capacities and the gaps in trainings, for example, from where Dr. Nand was speaking from that point. So these systems need to be in place, and it's a continuous cycle.
Okay. Like this DIR implementation is being done in other countries as well. So is there any point that we can learn from them? And
that was one thing which you can learn, which we can learn, we all should learn, is accountability. You bring in accountability, the rest happens on the side.
Thank you. Thank you. Is there any other question that that anyone would like to ask to the panelists, or anything that you would like to ask?
One thing, you have started this program recently, and at the end of the year or two, you will be asked about the result of this. With this government option, can ask you about results. So, have you addressed the gaps which are there? Because one thing is a procedure of implementation, which is very good. The program is very good, but the, the acceptance are from the public side is another thing. So some of the countries in the developing world, what they have done, to make it more successful, they have done the village level committees. People will go there, address them about the benefit of these vaccines, and by this way, the public, involvement is very important in any program. Because once I have my experience, I can say you once with the typhoid vaccine, when we go out in the villages, even the far-fetched villages, the hundreds of children are coming on the single day. By just motivating the notable people out there and having the meeting with them, that tomorrow there will be vaccination. And we have got a record of it. Billu was there, Iqbal Memon was there, and even Dr. Khalid Shafi was there, Dr. Jamaras was there. So we went to the villages, having initial meeting, and the hundreds of the children we have vaccinated on a single day. So that's very important. At the village level, there should be some group meetings with the notable, with the community should be involved. That's to make this program successful.
I think this is not the task of this IRDA. IRDA has the scientific part of developing this program. The task of motivating the people is the work of the health department, other professional associations, and the media.
They should be there. Otherwise, the program will not be successful. There is something that the community should be involved by that.
Sir, but don't you think that the role of the village doctor or the doctor in the interior, there are several of them, private doctors, their role is very important, because every family goes to them for one or the other reason, and that opportunity can be used कि यार इसके बारे में कुछ करें.
सर, अगर सिर्फ डॉक्टर्स अपना रोल अदा करने लग जाए, हम लोग ना, तो हमारी कवरेज 80% तो कहीं नहीं गई.
बिल्कुल नहीं.
अगर हम लोग ठीक हो जाए,
बिल्कुल नहीं.
20% में बढ़ेगी.
वही मैंने पहले कमेंट किया, मैंने जो डेवलपिंग वर्ल्ड ने सिर्फ 2 काम किए. एक तो जो जनरल प्रैक्टिशनर, फैमिली फिजिशियन, उनको इन्वॉल्व किया, उनकी रिस्पॉन्सिबिलिटी बढ़ाई, उनसे अकाउंटेबल किया उनको, तो उससे बहुत ज्यादा उससे फायदा हुआ. एंड यू आर वेरी राइटली सेड, उनके ऊपर बड़ा प्लीज.
But in this connection, we must develop some strategy of how to involve the village doctor or the small town doctors into this situation.
Exactly.
There has to be a well-conceived strategy.
Agreed. Totally agreed. Totally.
और जैसे कि सर ने बड़ी अच्छी बात की कि ये गवर्नमेंट और जो कि रिलेटेड इदारे हैं उनका काम है, IIT और इंडस हॉस्पिटल तो टेक्निकल पार्टनर्स हैं, लेकिन वी हैव डॉक्यूमेंट्री मेड अबाउट दिस डिजिटल इम्यूनाइजेशन रजिस्ट्री, जो कि बहुत जल्द हम उसको ऑन एयर करेंगे. ठीक है, तो उससे भी ये होगा कि एक आपकी अवेयरनेस बढ़ेगी, और अवेयरनेस के अलावा मतलब इट विल बी अ पार्ट ऑफ सोशल मोबिलाइजेशन. लेकिन असल में इस मुल्क में बिहेवियर चेंज कम्युनिकेशन हमेशा से वीक रही है ऑन सर्टन थिंग्स लाइक न्यूट्रिशन एंड एज वेल एज इम्यूनाइजेशंस, और इस पे कभी किसी ने कोई तवज्जो नहीं दी. दे आर नॉट सेपरेट डिपार्टमेंट्स हु शुड हैव वर्क ऑन BCC, और BCC बिहेवियर चेंज कम्युनिकेशन को एम्बेड करते हैं हेल्थ सिस्टम की डिफरेंट चीज़ों के अंदर. दूसरी चीज़ ये है कि आप देख रहे हैं कि ऑलरेडी कुछ LHWs ऑन बोर्ड, और अभी तक लेडी हेल्थ वर्कर्स जो हैं वो हैं जिनकी छोटी विलेज हेल्थ कमेटीज बनी होती हैं, और उनके ग्रुप्स होते हैं जहाँ पे वो औरतों को मोबिलाइज करती हैं चीज़ों के बारे में. सो दे आर ऑन बोर्ड, और वो भी कुछ वैक्सीनेशंस प्रोवाइड कर रही हैं, तो उनके थ्रू तो हो रही है. लेकिन देयर हैज टू बी अ रोबस्ट सिस्टम इन प्लेस फॉर बिहेवियर चेंज कम्युनिकेशन.
Sir, this reminds me of 1944, the Second World War. The British were trying to inform the public about how the war is going, and I remember in the district of Harparkar, which is Mirpukhaz, etc., there would be a van. That van was organized by a private important citizen. And this would go into the villages, show a movie, and then also show what is going on in the war. But I think this sort of approach can be of great help in convincing the villages and the small towns for this.
Right. Thank you very much. After this discussion, this session comes to an end, and I think so that what we have summarized over here is something much more better than what I was thinking of summarizing. So, in any ways, thank you very much.
Sir, can I ask you, has Department Government of Sindh represented here?
Yes,
Sir, you are.
Okay,
But I wish there were more doctors and more people from the health department.
Can I just make a final comment?
Please.
I worked with Ciro de Coseros, who was working with PAHO, and then he was the man behind measles eradication in Latin America. One day we were sitting and we were having lunch. He was my boss, and we were talking about polio. Pakistan is for the past 15 years in the limelight of polio and polio cases. So I used the word routine. So he said that, what do you think? Polio is not routine immunization? Should it not be routine immunization? And that clicked to me. And he said that until we get away from this division of routine versus campaign, he said these campaigns are also part of the routine immunization. So as long as Mr. Mehman is gone, but polio has really affected us. It's a poor program. We all have to accept this. Since 1944 and 2017, we still are not polio free. I will not consider this a good program. And on the side of it, it has really affected what the routine, so-called
Sir, I
routine
beg to differ with you on this. The polio situation in Pakistan has been because of mismanagement. The organizational setup of polio today is an example for the whole world, the way the whole thing is operating.
And it takes 30 years for a program to complete, then
because it was mismanaged. It was mismanaged. And now, with the world pressure, we have woken up, and I think this year should see the last of
I am a medical officer or I am a health worker, and I am asked that I leave family planning apart, leave routine immunization apart, leave everything. You have to do this, otherwise you can go even into jail. So every program is compromising because of polio program and campaigns, not only.
We should not talk like this at the moment. Because for the last moment for the polio, we have to work with the more determination and more commitment. Now this is the last year. If we are loose, we are fatigue here.
There are other vaccines.
No, there are other vaccines. The strategy is not to eradicate the polio. We have to control the measles and the other things also. We can give the example of the measles. There was the epidemic of the polio for the last measles in Karachi for the last 2 years. There was a special campaign for the polio 3 months back. Now this November, December, the hospitals, there are almost no patient with the measles. Last 2 years, many children died with the measles.
Yes.
But because of this campaign,
measles campaign held in August.
This effect of that
And whole
campaign is
polio
now
force
here.
was involved in this measles campaign. This is the first time that
got a very good result with the measles campaign.
But it will not last long, it's not sustained until unless
It is followed by the routine immunization. Routine immunization is the key to the success.
No, but sir, these are two separate issues. The question is, question is, eradication of polio is one objective, and routine is another way, which is going to go on and for many years. So let us not say one aspect is one. If it has happened because of mismanagement, because polio has nothing to do, doesn't come in the way of routine. It is the persons operating the systems who want to find an excuse कि जी पोलियो की वजह से हम ये नहीं कर सके और वो नहीं कर सके।
सर ऐसे ही हुआ है कि पोलियो की वजह से बहुत सारे काम सफल हुए हैं, लेकिन पहले जो सफर हुए हैं, अब पोलियो को तो खत्म कर दें ना, फिर हमारी जान छूट जाएगी, हमारे लिए बड़ी आसानी हो जाएगी, फिर बाकी प्रोग्राम में कंसंट्रेट कर सकेंगे.
This is why PEPS energy has come over and there's work in polio eradication area as well. If routine is strengthened, you can contain and sustain.
No, there is no doubt. No doubt. Strengthening of routine will expedite polio eradication. There is absolutely no doubt.
And you know what the strengthening is, the health secretary said recently that it should not be routine. Words will change the essential vaccination. That's important. So government is considering this as it should be essential immunization, not compulsory.
Yes. Bari, would you like to
actually, I think there is one thing. Basically, it's a political will. If political will is there, and if we have a right person for the right job at the top, unfortunately, the posting of the top man for immunization has always been political, not competent, unfortunately corrupt, unfortunately. If you don't do it, if you do it and decide he will do it, I think so. Routine immunization, you can achieve your targets. Now he's giving you incentive. If you do this, we'll give more to it, 100% more. Absolutely. There are so much incentive to it. But the major problem, which I think is there is no right person at the top who will take the responsibility and get one person right, and you will achieve your targets.
Thank you, Dr. Bari, for your final comments.
Sir, in this I would point out that PC1 that was mentioned here, it's absolutely important that it must come into force as soon as possible. Without that, results will not come. And sir, let me point out that EO's routine is still being handled as a project. It is not being handled as one important issue in the health.
Not integrated with the.
Not integrated. It is run as a project. So, and you see the system that operates in polio, but this little project of routine, that is the problem. And I think the government has sanctioned large sums of money on this PC1. But I hope to God that PC1 comes effective as soon as possible.
Thank you very much. And with this, we come to an end of this session. And for the memento presentation, I would like to call Dr. Bari. Please come over here and hand over the shields. Bari is the CEO of Indus Hospital and an eminent cardiac surgeon. First of all, I would like to ask Dr. M.N. Lal to kindly come over here and please receive your shield. Dr. M.N. Lal.
Thank you.
Thank you. Dr. Ali Turab. An excellent presentation on the Zindagi Mahfooz program.
Okay.
Dr. Imran Khan. Dr. Mohammed Imran Khan from Khan University Hospital.
Thank you.
Dr. Ayaz Somro from UNICEF.
Thank you.
Dr. Tanveer Hussain. Mr. Aziz Memon left due to some yeah, please. I would like to call upon Masood Ahmed Bhari Saab.
I'll deliver it to you.
Please. And I think the last shield is for myself.
Thank you.
Thank you.